Like I said, we're going to talk about stress testing today. The first part of the lecture is really going to be who needs to have a stress test and who doesn't. So just taking it from the top, if we talk about stress tests in general, um, the you guys can see me. The general indications for stress testing are any symptoms consistent with angina, patients who had ACS or unstable angina that's included under ACS that were treated with medical management. Those people need to wait at least 48 hours um, after their MI before you stress them. And then patients who have had incomplete revascularization, typically in the setting of AVS or ACS. Anybody with new left ventricular dysfunction, it's stress versus cath them. And then for pre-op evaluations. The big contraindications you need to know before you're even considering stress testing is if somebody has had a heart attack within the last 48 hours or has active unstable angina, you should not be stressing them. Uncontrolled arrhythmias, because a lot of the ways we stress people can induce arrhythmias, unfortunately. If they're in decompensated heart failure, they're already giving themselves a stress test. Any acute myocarditis or pericarditis, or any suspicion for aortic dissection. The relative contraindications are hokum. We do stress those people under, I would say, very controlled circumstances, but not in the kind of ischemia stress test sense like we're going to focus on today. Anybody who has known left main disease, I can't really come up with a reason you would be stressing them, but that's probably a bad idea too. And then people who are really hypertensive, because again, some of our stress methods can cause their blood pressure to go even higher, and then you end up at risk for dissection and stroke and all kinds of stuff. So the first thing you have to do when you're seeing a patient in the emergency department is classify their chest pain. And I know this is something like all you guys know, but it's really important for risk stratification moving forward. So there's three features for cardiac chest pain. It should be substernal, with appropriate duration and quality. It needs to be triggered by exertion or emotional stress, and then relieved by nitro or rest. One of the kickers with relief by nitro or rest is it should work in minutes if it's going to work. The people who come in and say, "Oh, I took a nitro in 45 minutes, my chest pain got better," it probably wasn't the nitro that did that. So, out of these criteria, if you have zero or one of them, it's classified as non-anginal chest pain. If you have two of them, it's atypical angina, and then three are typical angina. Um, this is data from the old Diamond Forrester criteria, which we reference all the time when we talk about risk stratification. I highlighted, yeah, right here, some of the more important stuff on the next slide. So when you look, you've got age on the y-axis and then all kinds of angina classification and then sex on the x-axis. So being a man by itself is a risk factor, and then increasing age is a risk factor too. And then your story is exceptionally important too. You only break the 20% mark for likelihood of coronary disease and non-anginal chest pain when you are both a man and in like the prime area for having CAD. So that's why we care so much about the story when we come to see patients. Atypical angina are the people we always struggle with, and that's when, like I said, age and sex come into the equation, along with other stuff which weren't included in Diamond Forrester, but diabetes, hypertension, previous CAD history, etc. As far as typical angina, those people are pretty much slam dunks unless you have a young woman who is describing typical angina. But outside of that, extremely high likelihood of CAD. I covered those things. So the important thing about this is to classify people into low risk, intermediate risk, and high risk patients. Um, your low risk patients, if you stress them, you have a higher chance of getting a false positive and then sending them to the cath lab or sending them for a stent than an appropriate test result. And then your high risk patients, you have a elevated chance of getting a false negative test and not getting them the treatment that they need. So the intermediate risk people are the ones we're really looking to do stress tests on because it's actually going to change our management. And that's probably in your kind of 40 to 60% range. Once you get up above 60%, you should be thinking about going straight to cath. So you've seen somebody and you've decided you're going to stress them. The next thing to do is like a quick pre-stress evaluation. One thing that unfortunately we run into from time to time is that unstable angina and ACS have not been ruled out yet before we go to stress people. And then the second thing we get a bunch of questions about is what meds should people be on. So I kind of go through them here in groups. But beta blockers, nitrates, and calcium channel blockers, which are our big anti-anginal meds, they reduce the sensitivity of our stress tests, but they are not. They can be continued under appropriate circumstances. They improve myocardial blood flow or they decrease myocardial oxygen demand just based on their mechanisms. That's why they decrease the sensitivity of our stress tests, because we're trying to increase myocardial oxygen demand so that we can see if somebody has ischemia. So, if possible, you want to stop all those 48 hours before a stress test. Nitrates can almost always be held. If a patient is getting like a nitro drip or continuous or frequent sublingual nitro to keep them from having constant chest pain, we should probably go back to step one here and make sure it's not unstable angina. Um, Beta blockers, they should be continued if they're used for arrhythmia control or if patients have depressed EF and LV dysfunction, or if they've had ACS in the last 12 months. So basically kind of the guideline-based indications for beta blockers. For calcium channel blockers, so the research is all on dihydropyridine calcium channel blockers, which we don't see nearly as much of as we used to. That's verapamil and diltiazem, but it gets applied to all of the calcium channel blockers. So when we have patients on amlodipine and nifedipine, we say that maybe those reduce the sensitivity of stress tests as well. The one caveat for calcium channel blockers is those need to be continued if people have documented history of vasospasm, which is rarely confirmed in the cath lab, but if they have that, keep them on their calcium channel blockers. And then maybe for blood pressure control. If they need their Norvasc to keep their blood pressure 170 systolic so we can actually stress them, then it's probably better to do that and stress them than to stop their calcium channel blocker and then have us run into the blood pressure criteria we talked about earlier. All right, now we're into choosing stress tests. So really the first thought in everybody's mind, even though it's usually the last thought for you guys and myself, is to exercise these people. The rule should be always exercise the patient. You need to find a reason not to. Practically, the only contraindication to exercise is safety. If a patient can't walk on a treadmill or is wheelchair bound or has bad knees or hips like all my VA patients, then those people you probably shouldn't put on the treadmill. But in reality, I often still try because both of our stress labs here and at the VA will convert people from exercise studies to pharmacologic studies if they need to. I talk about it in a couple slides, but the reason exercise is so important is even if that's not what you're using to detect ischemia, you get tons of prognostic data from it. So test purposes, so you guys may run into these on your medicine boards, but reasons not to exercise people are low exercise tolerance if it's unsafe, and then they love to test on left bundle branch block, LVH on their EKG, or V pacing. Those would mean that you need another way to you need another way to detect ischemia. I see somebody asked about caffeine in here. So caffeine just needs to be held day of stress test if you're going to do regadenoson, because it's the antidote to regadenoson, which I think I've gotten a couple slides here. So no black coffee in the morning, no Mountain Dew after midnight, all that good stuff. As far as pharmacological stress tests, practically, again, the only reason to do them is if people are unable to exercise or you need to do an alternative imaging method for a different reason, which again we'll get into later. And then for test purposes, if they're V-paced or have a left bundle or LVH, that's when you head for pharmacologic, and you need to use imaging in those people as well. Oh, which I have right there. So they can still exercise, you just have to get imaging of some kind so you can actually interpret for ischemia. Okay, the tried and true exercise EKG, which we see very few of. In our lab, it's probably, 10% at most of the studies. So what we do is we put people on a Bruce protocol or a modified Bruce protocol. What the Bruce protocol is we put people on a treadmill, and the incline and the speed of the treadmill increase every 3 minutes, all the way up to 21 METs. And we follow their heart rate, and it is considered a diagnostic study if they hit 85% of their, that says target heart rate, that's a mistake. It's 85% of their theoretical maximum heart rate, so 220 minus their age. We interpret for ST changes. If they have ST depression, that's considered positive. If they have ST elevation, that's considered positive. So we had a I don't know about the VA record. The VA record's probably about a minute, but we had somebody here who their PCP referred them for chest pain. They were a UC athlete, and they went for like 22 minutes, and we actually had to stop the test because they had maxed out the treadmill and they hadn't hit their target heart rate. Probably not an appropriate test, but that's okay. So it goes back to risk stratification at the beginning. But anyways, ST depression of 1 to 2 millimeters is considered positive. You have to see that consistently several beats in a row. Typically, we like to see it regionally as well. ST elevation is extremely high risk and not only positive, but a reason to immediately stop the test and get those people to the cath lab because it means they're potentially having transmural ischemia. We see arrhythmias when we exercise people too, but that does not indicate a positive test. Um, the Duke score is one of the most important things we can get when we exercise patients. Um, Unfortunately, it only applies if you get people to close to their maximum heart rate. So they have to hit, oh, sorry, getting paged. So they have to hit 85% of their maximum heart rate for you to give them a Duke score because that's how it was validated. The way we calculate it's their total exercise time minus 5 times however many millimeters of ST change they have. So 1 millimeter is 1, gets you 5, 2's 10, blah, blah, blah. And then 4 times the angina scale. So we ask these people every 3 minutes when the treadmill goes a little faster and gets steeper if they're having chest pain. If they say no, they get no points. If they say they had some during the test, they get 1 point, which you multiply by 4. If they have to stop the test because of chest pain, they get 2 points, which you multiply by 4. Way back when they did this study, they found that this score predicted your 5-year mortality. So a low risk study is a score of greater than 5. You end up with 97% survival. Intermediate risk is any score from negative 11 to 5. That's a 90% chance of 5-year survival. And then high risk is, that's signed the wrong way. It's less than negative 11. And that's actually a really poor prognostic marker. So as far as the ST changes, it only technically has to be in one lead, but they are more powerful when they're regional. Your inferior, if you really want to get into the nitty gritty of interpretation, your inferior leads, 2, 3, and AVF, you have to have at least 2 millimeters of ST depression. And your other leads, you only need 1. But that's probably beyond the scope of what they're going to ask you guys. Okay, so now we're going to move on to just the pharmacologic stress agents, and then we'll talk about imaging once we do the agents. So by far the most common ones are regadenoson and dobutamine. Regadenoson is an adenosine analog. It causes coronary dilation. So when you have diseased vessels, they are already maximally vasodilated at rest to try and increase blood supply to the downstream myocardium. So what happens when you give regadenoson is the healthy vessels then dilate, and you get essentially a steal phenomena from the unhealthy vessels, and that's how we detect our perfusion defect. Side effects with regadenoson, bronchospasm is one they love to ask about. It can also cause bradycardia and heart block, which makes plenty of sense because we give adenosine to induce heart block in people who have like AVNRT or really fast SVTs. So what you guys might see is you do not give it in either second degree type 2 heart block or complete heart block and any active COPD exacerbation. A patient who just has baseline severe COPD, it's a relative contraindication. If you guys see that on boards, the answer will be don't use it. The antidote for this is either IV or PO caffeine or IV aminophylline. And it's the reason that we have to have people not have any caffeine starting midnight before their test because the regadenoson won't work if caffeine's still in their system. Dobutamine is predominantly a beta-1 agonist. It increases your heart rate, contractility, and myocardial oxygen demand, so it's a really good simulation for exercise. Unfortunately, it's got a bunch of side effects. Hypotension and atrial ventricular arrhythmias are unfortunately common. The antidote for it is beta blockers, which we give plenty of times when we're doing dobutamine stresses. And the caveat is this is still a heart rate based test with dobutamine. So for it to be diagnostic, somebody still has to hit 5% of their maximum heart rate. That is not true with regadenoson. There are criteria for whether or not people had a regadenoson response, but they're much more commonly hit. I don't think in almost 2 years I've seen anybody who didn't have an appropriate regadenoson response. So those are our agents. Now we're going to get into how we actually detect ischemia, either with imaging or a nuclear study or anything like that. So when you're assessing for ischemia, you should be thinking about an exercise EKG again if the people can exercise and in general have a normal EKG, with the exceptions we talked about before. Here's the reasons to do imaging again, which I've probably already beaten to death. And the types of imaging is what we're going to get into next. So there's stress echo, which can be pharmacologic or exercise. There's stress MRI, which is pharmacologic only for now. There are some places doing exercise, but we're a ways away from that here. SPECT, which is your typical like Lexi scan that we do a lot of, those can be pharmacologic or exercise. And then PET, which are pharmacologic only for now. Kelly's in the room here and should get mad at me if I didn't answer or if I didn't say that soon we will be doing exercise PET too. This graphic on the right is just the sensitivity and specificity of these tests. And actually you can see exercise EKG, you're going to miss some, but it's really specific when it's positive. So it is a good test when appropriately applied. Essentially, as you get into more advanced imaging techniques, your sensitivity goes up and your specificity goes up minimally. This is old SPECT data. The sensitivity is not as low as 70%, and the specificity is not as low as 60%. They're probably in the mid 80s now. Dobutamine stress echo, that's pretty accurate, about 80 and 80. Dobutamine stress MRI, we don't do a ton of anymore. It's typically regadenoson now, and those are approaching sensitivities in the high 90s and specificity in the high 90s. Same thing with PET, is sensitivity and specificity in the high 90s. Coronary CTA, I'm not going to talk about. And then the vasodilator stress SPECT is just the regadenoson version of the exercise. And you can actually see it has really pretty good sensitivity and specificity too. All right, so stress echo. Again, we use either exercise or dobutamine as a stressor. We take images at baseline, at peak stress, and then at recovery, which is when their heart rate's drifted back under 100. Basically, what you do, and hopefully this is playing for you guys on the right, but you can see up here, these are your rest images, and this is actually a dobutamine, but it's the same for exercise. These are your baseline images over here. This is an apical 4-chamber, so LV, RV, LA, RA. This is your low-dose dobutamine, same views. This is they've got it mixed up a little bit. This is your peak dose, and then this is recovery down here. So essentially what you do is you go through the LV wall segments at baseline, and you see if they all augment appropriately at low dose, which they do, and then you go to see if they all augment appropriately at high dose. If it actually doesn't, you can see this mid to apical, and just trust me on this if it's hard to see, but you can see this mid to apical inferoseptal segment is no longer coming in as quickly or as much as it was at low dose. And then it goes back into recovery, and you can see that the myocardium is now in that area, is coming back in. So you would call this study positive in that area. Pros of this kind of study are you get baseline functional information. So here at UC, we do a complete echo with every stress echo, which is great, especially if people need a general echo too. Most places don't do that and only get stress images, so you don't get a ton of information outside of ischemia. Cons, obviously it has worse sensitivity and specificity than some of the nuclear studies and MRI that we're going to talk about. Really, the vast majority of people we still do these in are our pre-liver transplant patients, because there's pre-liver transplant data on dobutamine stress, and our hepatologists like them. We have a few interventionalists that still like them too, but for the most part, we're not doing a ton of these anymore. SPECT is next. So what we do in SPECT is we give people a radio tracer. In our case here, we use technetium. It distributes to the heart via coronary circulation. Photons are then emitted from the heart and captured by a camera. We then stress them either with exercise or regadenoson, and then we repeat that same process, and then you compare the rest and stress images. So the pros for this one, it's got increased sensitivity and specificity compared to EKG and echo. The cons with it are artifact and radiation dose. So you can get artifact from breast attenuation, from morbid obesity, from bowel uptake, patients moving underneath the camera, a number of things. One of the other things that you have to worry about in SPECT is that it can miss balanced ischemia or 3-vessel disease. The typical population for this study is, this is kind of the go-to test for the average risk patient who comes in through the ED and can't get an exercise EKG. So we've got two different sets of images over here. This is what it looks like when we actually compare them. So on the left, you've got a reversible perfusion defect. This is the short axis of the LV along the bottom. This is rest. This is stress. Short axis again here. And you can see once you get to the mid-myocardium, you have dropout of the aneroseptum, the whole septum, and the inferoseptum. So it's normal at rest, worse at stress. You'd call that a reversible defect. You on any SPECT study, you want to confirm it in multiple views, so you can see it here as well. This is the long axis of the heart. So here you've got normal perfusion in the septum, and then it disappears. This is a fixed perfusion defect here on the left. It's just what it sounds, or on the right, it's just what it sounds like. The inferior wall's toast at rest and stress. Same thing in your other views. That's pretty much it for SPECT. PET-CT is going to be next. So for this one, we use a rubidium radio tracer. Again, for now, there are some people working on some other radio tracers. It's the same protocol as SPECT, essentially, but it's positrons that are emitted instead of photons, so they're higher energy and you get better resolution. They're detected using a similar camera and then CT scanner, which allows you to correct for attenuation and overcome some of those artifact problems that we had with SPECT. So the pros for this one is it has really, really good sensitivity and specificity, like mid 90%. You also get coronary flow and coronary reserve information, so it won't get fooled by balanced ischemia like a SPECT will. Obvious cons for this one is radiation exposure again, and the people you should think about when you're doing it are patients who've had prior CABGs or prior interventions, and you're trying to figure out where the ischemia is and if they would need stents and where. People with really high BMIs, because the higher energy photons overcome the attenuation. Sounds like we got another question. Can I describe balanced ischemia? I can. So balanced ischemia is really just a synonym for basically three vessel disease. If you have ischemia in all of the vessels, what these tests do is they pick up relative changes. So ischemia in all vessels is going to look normal on your stress images because everything is going to have worse uptake. Does that make sense to everybody? Should have put an example in here. Okay, great. And PET-CT is likely, it's growing in popularity here and basically everywhere that has the capability to do it, so it probably is going to overtake SPECT at some point. It looks quite similar to our SPECT images. So again, rest on the bottom, stress on the top. These are your short axis images. These are your long axis. You can see the anterior wall drops out at stress in two views. That's a reversible defect. Same thing with the inferolateral wall. Neither one is particularly good at evaluating the RV. For RV evaluation of any kind, an MRI is by far the best test, but there aren't great tests for RV ischemia. Even echo for like RV function is just okay. You can tell if an RV is like wildly dilated on a PET or a SPECT, but that's about it. Next is going to be stress MRI. This one's going to take a little bit longer to explain. Not a ton, I think just 2 slides. So what we do is we obtain baseline MRI images, we give a regadenoson stressor or dobutamine, but we use regadenoson here, and you obtain stress images. So with each of these images, you give gadolinium contrast. So what gadolinium does is it starts in the bloodstream and then distributes evenly to the myocardium and then distributes to the extracellular matrix where it really likes to hang out if you have a lot of extracellular matrix. And that's what we talk about if you ever see delayed gadolinium enhancement on any report. Because the GAD goes to the extracellular matrix and it stays there a really long time, hence delayed enhancement. And when you've had an MI and have scar tissue, you have increased extracellular matrix as opposed to normal myocardium. So it's essentially a surrogate for scar tissue within the myocardium. So on a normal study, and I've got an example of this on the next slide, I think. But on a normal study, you get normal gadolinium uptake, normal washout at stress and at rest, and no delayed enhancement. Ischemic myocardium, you get normal or decreased uptake at rest. And then once you stress them, you have no uptake or a further decrease in uptake. If there isn't any scar, the gadolinium won't hang around late. If there is scar, it will. You can obviously have mixed scar and ischemia. And your ischemia is always in an endocardial pattern, which means starts from the portion of the myocardium that's closest to the blood pool and extend towards the epicardium where the coronaries lie. Makes sense because that's the furthest downstream, so it's the most sensitive to ischemia. SCAR has no uptake at stress or rest. It has delayed enhancement in both. And you can actually get some viability information from stress MRI as well. If greater than 70% of the myocardium has delayed gadolinium enhancement in an endocardial pattern, that is not viable tissue. Just to touch on some other stuff, infiltration has a mid-myocardial pattern or an endocardial pattern, and it's patchy and not in a coronary distribution, and then my indents got mixed up. But inflammation or myocarditis has an epicardial pattern, so from the outside in. I like this little ding for questions. Stress MRI isn't the only modality that provides viability data. There are but it is the only one that with its typical sequence can get you viability data. So there are PET viability studies which have better overall data for detecting myocardial viability, but it's a special sequence that you have to run, and it's a multi-day protocol. You don't get it with your regular PET stress test. But a stress MRI, this is information you can get from it. SPECT cannot give you viability, nor can an echo or exercise EKG. All right, so the pros for stress MRI is you get a ton of functional and anatomic information too. It will help you diagnose your non-ischemic cardiomyopathies, like I talked about on the last page. Extremely high sensitivity and specificity, and you get viability information. There are people working on flow reserve data too, just like in PET. Cons, it's a long study. It's in duration, probably about the same length as your other stress tests. But the problem is people have to spend a long time in the MRI tube, about an hour or so, and they have to be able to breath hold and cooperate with the exam, and it doesn't go great for everybody. Obviously, gadolinium contrast, if you have ESRD, they are really not candidates for this. The really good people to use this in are, we're seeing it a lot more in our new cardiomyopathies. So that unexplained low EF consult we get for somebody who comes in who, isn't having ACS right now. Stress MRI will give you both active ischemia data and if they are scarred down and in what pattern, and oftentimes can lead to a diagnosis with just one test instead of several. It's also great if you suspect structural disease because you get a ton of structural information from an MRI. So what we've got here is essentially the same thing that you see in the other imaging modalities. Stress is on top, rest is on the bottom. This is the short axis of the heart. We're going apex, mid, and base here. And you can see at the apex at rest, the cardium is relatively white. That's the gadolinium perfusing in normally. At stress, your septum is still white, but your whole lateral wall is much darker than the septum, so that would imply that there's ischemia there, and it extends up into the mid segment, not so much at the base. A normal study would essentially the rest and the stress look the same, and then if you had SCAR, you would have no uptake at rest, no uptake at stress, and then evidence of delayed gadolinium enhancement in both views. Okay, interpreting results. So for all these stress tests, it's important to know if they're high risk, intermediate risk, or low risk. So high risk studies, technically speaking, show a multivessel disease pattern, extensive LAD or left main flow abnormalities, any EF drop with stress, any blood pressure drop with exercise, or any ST elevation on EKG. That's with exercise or with a pharmacological agent. People who have high-risk studies have to get a cath because stenting or CABG in these populations improves mortality. Intermediate and low-risk studies is all the other stuff. Those people do not have to be cathed. They can be medically managed, aspirin and statin for their CAD, beta blockers, calcium channel blockers, and nitrates for their angina. These people should only be cathed, according to guidelines, if they have refractory symptoms or can't tolerate their medical therapy. Stents for symptoms do not change anybody's mortality. I will be honest and say that our stress lab here doesn't stick to these strict criteria for whether a study is high risk or not. If we find a decent amount of ischemia, we will call it a high risk study, even though strictly speaking it isn't. And for many of our studies, no matter what the risk, if they are positive, we send a lot of these people to the cath lab. But just so you guys know, that's not the way it's done everywhere, and it's not necessarily something you have to do. That was, I think, all I had. Yep, that's it, unless you guys want to go through it again. So what questions do you guys have for me? Yeah, that's a good question. As far as cost. So exercise EKG is the cheapest. But SPECT, PET, and MRI actually have quite similar costs at this point, both to the hospital system and to the patient. Yeah, and yeah, PET here is currently twice the price of everything else. It's when you look into it everywhere, it's not that case everywhere, but it has to do with how you have to generate the radio tracer and how you get a hold of it. I didn't talk about TID. So TID is what's termed transient ischemia. It is the finding that you can see on a SPECT that can sometimes hint that somebody has balanced ischemia or three vessel disease. What it is the software will measure the circumference of the cavity at rest and at stress, and it comes up with a ratio of the stress cavity size to the rest cavity size. So transient ischemic dilation is just what it sounds like. It's dilation of the cavity with stress as compared to rest. And what it is not actually a true dilation of the cavity. It's because the person has significant ischemia, usually in all three vessels. So the radio tracer no longer gets all the way to the innermost extent of the endocardium, which appears on your camera as the cavity being larger, even though it's actually just a lack of appropriate myocardium. That's really only assessed on SPECT. You can assess it on PET too, but the flows give you enough data that it's not something we rely on as much there. That's a good question. How long is a stress test valid for? There's not really an easy answer to that. If somebody had a stress test a week or a month ago and their symptoms are exactly the same, even 6 months ago and their symptoms are exactly the same, then it's likely similar. The problem with ACS and unstable angina is it's from all the research we've done, it's the 30, 40, 50% plaques that tend to rupture, not the 70, 80s. So those aren't picked up particularly well on any of our stress testing. So it really requires you reassessing the patient and risk stratifying them again from the beginning. I've seen patients come into our lab with MIs who had stone cold normal stress tests as recently as a few months before they showed up on the table. 5 to 7 years, specifically in your question, is much longer than I think anybody would say a stress test is valid for.